Welcome to the Deep Dive. We're here to help you get informed fast. Today we're diving into something really fundamental in pediatric nursing. Nursing care of the child with an alteration in comfort, specifically pain assessment and management.
Yeah, this is such a critical area. It's not just abstract knowledge. It's about really helping kids who often can't just tell us what's wrong.
Right.
We talk about pain being the fifth vital sign, but actually managing it in pediatrics is, well, it's tough. Communication is often the biggest hurdle.
So we need solid definitions to guide us.
Exactly. The International Association for the Study of Pain gives us the technical one. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage.
Okay, sensory and emotional, that's key.
Definitely. But for us nurses, day to day, McCaffrey's definition is maybe even more practical. Pain is whatever the person says it is, existing whenever the person says it does.
Even if that person is a nonverbal child, showing us through behavior. And this really matters for you listening because, well, ignoring or undertreating pain in kids isn't just about immediate suffering.
Oh, absolutely not. It can have serious long-term consequences.
Like what kind of things?
Well, physiologically, you see increased oxygen consumption, higher metabolic rate, things that hinder healing. But emotionally, it can lead to increased anxiety with future procedures, even potentially setting them up for chronic pain later in life.
Wow. So getting this right is huge. It's about assessment, intervention, and then crucially, reassessment.
That cycle is everything. You can't just treat and walk away.
So to manage it effectively, we need to understand how pain even works in the body.
Right. Let's map out the basic pathway. There are essentially 4 key events in how we sense pain.
Okay, walk us through it. How does the body first register an injury?
It all starts with transduction. Think of it as the ignition. Some kind of harmful stimulus could be mechanical pressure, a chemical burn. Extreme temperature activates specialized nerve endings in the tissues.
Those are the nociceptors.
Yep, the nociceptors, they're the body's alarm sensors. Once they're triggered, the alarm is on.
Okay, alarm's ringing. How does that signal get to, well, headquarters?
That's step 2, transmission. The electrical impulse generated by the nociceptors travels along nerve fibers up towards the spinal cord.
There are different types of fibers, right? I remember learning about fast and slow pain.
Exactly. There are the fast myelinated A delta fibers. They carry that sharp, immediate, ouch kind of pain. Then you have the slower, unmyelinated C fibers, responsible for the dull, aching, throbbing pain that often lingers.
Okay.
And this is where the gate control theory comes in. It's a bit of an older model, but still useful conceptually.
How does that fit in?
It suggests that there is a sort of gate mechanism in the spinal cord. Stimulating other larger nerve fibers, like when you rub a bumped elbow, can actually close the gate to the pain signals traveling on those smaller A delta and C fibers, reducing the pain you feel.
Ah, so that's why rubbing it actually helps?
It's the basic principle behind things like massage or 10NS units.
Interesting. Okay, so the signal gets past the gate. Where does it go next?
It ascends to the brain, primarily hitting the thalamus first. This is perception. The thalamus acts like a relay station.
Relaying it where?
It sends the message to different parts of the brain. To the somatosensory cortex, which tells you where it hurts and what it feels like physically, and also to the limbic system, which handles the emotional response, the fear, the anxiety, the unpleasantness of it all.
And that point where you first notice the pain, that's the threshold.
Right. The pain threshold is the minimum intensity of stimulus that you perceive as painful.
Got it. So transduction, transmission, perception. What's the last step?
Modulation. This is where the body tries to control the pain message. It can happen both in the spinal cord and the brain.
How does it do that?
Through its own natural pain relief chemicals, neuromodulators like endorphins and serotonin, these can inhibit the pain signals, effectively turning down the volume.
So the body has its own built-in pain management system to some extent.
It does. Modulation can either dampen the pain signal or sometimes, unfortunately, amplify it.
Okay, that physiological pathway helps understand the how. Now, how do we categorize pain? You mentioned duration earlier.
Yeah, that's the most basic split. Acute pain is, sudden onset, usually linked to a specific injury or illness, and it generally resolves as the tissue heals. It serves a protective purpose, tells you to stop doing something harmful.
And chronic pain.
That's the tough one. It persists beyond the expected healing time. The textbook often says 3 months or more. It loses that protective function and just becomes debilitating. It interferes with sleep, school, play, everything.
Then there's classification by cause, or etiology.
Right. The most common type we deal with is nociceptive pain.
Hmm.
This is your standard pain from tissue damage, a cut, a broken bone, inflammation. The nervous system itself is working correctly. It's just reporting the damage.
Versus.
Neuropathic pain. This is different. Here, the nervous system itself is damaged or malfunctioning. Think diabetic neuropathy or pain after spinal cord injury.
And it feels different, right?
Often, yes. Patients describe it as burning, tingling, shooting, pins and needles. It requires different treatment approaches than nociceptive pain. You can't just throw standard painkillers at it effectively.
That's a really important distinction for treatment. Okay, within nociceptive pain, there's also somatic versus visceral.
Yeah, it's about the source of the pain. Somatic pain comes from tissues like skin, muscles, joints, bones. It's usually well localized. You can point to where it hurts and described as aching or throbbing.
Like a sprained ankle.
Exactly. Whereas visceral pain originates from internal organs, the gut, bladder, chest organs. This pain is often harder to pinpoint, feels more diffuse, deep, maybe cramping or stabbing, and it often comes with other symptoms like nausea or sweating.
Like appendicitis pain, maybe?
Good example. It's often vaguely located around the belly button initially, then might move.
Okay, understanding these types is crucial. Now, let's talk specifically about children. Their experience of pain isn't just a smaller version of an adult's, is it?
Not at all. Several factors influence a child's pain experience much more significantly. Some things we can't change.
Like their age.
Right. Age is huge. We know now that the neurological pathways for pain are developed even before birth. Infants, especially preemies, might actually feel pain more intensely because their inhibitory systems aren't fully mature yet.
What else is sort of fixed?
The child's cognitive level, how well they understand what's happening, why they hurt, and how they can communicate it is directly tied to their cognitive development. This is especially important for kids with developmental delays.
Makes sense.
Then there's temperament. Some kids are just naturally more sensitive or reactive. And previous pain experiences, a bad experience, can unfortunately sensitize them, making future events more stressful.
And family and culture play a role, too.
Absolutely. Family and culture shape how children learn to express pain, what coping strategies they see modeled, and even what meaning they attach to pain.
So those are the things we mostly have to work with. What about factors we can influence? The situational stuff.
Yes, this is where nursing interventions can make a huge difference. Think about the child's anxiety and fear levels. A terrified child will perceive pain as much worse.
So preparation is key.
Crucial. Also, their lack of understanding. If they don't know why a procedure is happening or how long it will last, it increases distress. And sometimes family behaviors, while well-intentioned, an overly anxious parent can sometimes escalate the child's own anxiety.
Helping the parents cope helps the child cope.
Definitely. Providing support and education for the whole family is part of managing the child's pain.
Okay, so knowing these factors helps. Now let's get practical. How do kids at different developmental stages typically show us they're in pain? Starting with the littlest ones, infants.
Right. They can't tell us, so we're detectives. We look for behavioral cues. That distinct, high-pitched, tense cry, a grimacing facial expression, maybe they're rigidly holding their body or thrashing around.
And physiological signs.
You'll often see physiologic changes, too. Increased heart rate, faster breathing, maybe sweating, and sometimes a drop in oxygen saturation levels, especially in preemies.
Okay, moving on to toddlers. They have some language, but
it's limited. They might use simple words like "itchy," "boo-boo," or point vaguely. Their reaction is often intense and physical. Lots of crying, screaming, maybe hitting, kicking, pushing you away.
And regression is common too, right?
Very common. They might become extra clingy, refuse to potty train if they were starting, demand a bottle again. It's their way of coping with the stress.
Then preschoolers. Their imagination starts playing a bigger role.
Yes, hello magical thinking. They might think the pain is punishment for something they did wrong. This can make them withdrawn or hesitant to admit they hurt.
So they might hide it.
They might. They can usually point to where it hurts, but they really struggle to describe the type of pain or rate its intensity accurately. Asking them how much it hurts might not yield reliable info.
Got it. School-age children now, they can communicate better, usually.
They can. They can often describe the pain. It feels sharp. It's like pounding. They might even be able to use simple rating scales.
But there's a catch.
The catch is they might deny pain. Why? To seem brave, maybe they fear getting a shot or more treatment, or they're just embarrassed to cry in front of others.
So we still need to observe.
Absolutely. Look for nonverbal cues like clenched fists, gritted teeth, holding their body rigidly still, guarding the painful area.
And finally, adolescents. They seem like many adults,
But they have unique concerns. Body image is huge, so is maintaining control. They might try really hard to appear stoic or cool, even when they're in significant pain.
so again, don't just take their word for it if they say, I'm fine.
Never. Look for those subtle signs. Are they guarding? Is their breathing a bit faster or shallower? Are their fists clenched? Are they avoiding activities? These are your clues.
This developmental perspective is so critical. Before we get into assessment tools, let's quickly bust some common and frankly dangerous myths about kids and pain.
Yes, please. The first big one. Newborns don't feel pain, or feel it less. Utterly false. As we said, their neurological system is ready for pain signals from birth.
What about children will always tell you if they're in pain?
Also false, as we just discussed with school-agers and teens trying to be brave, and preschoolers might not have the words or might be afraid.
And the one about sleeping or playing. If a child is sleeping or playing, they must not be in pain.
This is a huge misconception. Sleep can be a sign of exhaustion from pain, and play can be a very effective coping mechanism or distraction. It doesn't mean the underlying pain is gone.
What about the fear of addiction? Giving opioids to children will cause addiction.
This is a major barrier to effective pain relief. The fact is, when used appropriately for acute, moderate to severe pain under medical supervision, the risk of iatrogenic addiction in children is extremely low. Undertreating pain carries far greater risks.
Okay, myths busted. So how do we approach assessment systematically? I know there's a helpful mnemonic.
QuestTT. It's a great framework.
Break it down for us.
Okay. Q is for question the child and the parents. U is use a pain rating scale that's appropriate for their age and development. E, evaluate their behavior and any physiological changes. S is secure parental involvement. This is key.
Why is parental involvement so critical?
Parents know their child best. They often notice subtle changes in behavior or expression that we might miss, especially initially. They are essential partners.
All right, and the two T's.
T is take the cause of pain into account. Knowing why they likely have pain helps interpret the assessment. And the final T is take action, assess, intervene, and then, crucially, reassess.
QuestTT. Okay, let's talk about those pain rating scales, the U. For kids who can self-report, what are our main options?
For younger verbal kids, roughly ages 3 to 8, the FACES pain rating scale is very popular. It uses 6 cartoon faces, ranging from a big smile, no hurt, to a crying face, hurts worse. The child just points to the face that shows how they feel.
Simple and visual.
Very. There's also the Oucher pain rating scale, similar concept, for ages 3 to 12, but it uses actual photographs of children's faces, showing different levels of discomfort.
Photographs, that's interesting.
Yeah, and importantly, it comes in different versions, showing children of various ethnicities, which can help kids identify better with the scale. It also has a vertical 0-10 number scale alongside the faces.
What about that poker chip tool? That sounds kind of different.
It is. The poker chip tool is for ages 3 up to maybe 18, sometimes older, if cognitively appropriate. You give the child 4 red poker chips and explain that these are pieces of hurt.
Okay.
You ask them, how many pieces of hurt do you have right now? 1 chip is a little hurt. 4 chips is the most hurt you could ever have. You have to make sure they understand that more chips mean more hurt.
Clever way to quantify it for kids who might not grasp numbers 0 to 10 yet.
Exactly. For older kids, typically 8 years and up,
Yeah.
who understand number concepts and sequence, the standard numeric rating scale, 0-10, works well. 0 is no pain, 10 is the worst pain possible.
And the VAS.
The visual analog scale, or VAS, it's usually a 10-centimeter line with no pain at one end and worst pain at the other. The child slides a marker or points to where their pain falls on the line. It can sometimes be used with kids as young as 5, but they need to understand the concept of a continuum.
Okay, lots of options for kids who can self-report. What about infants, preemies, or nonverbal children?
That's where observational tools are essential. For premature infants, the PIPP, Premature Infant Pain Profile, is great because it includes gestational age along with behavioral signs like facial expression and physiological signs like heart rate and oxygen saturation.
Specifically for newborns.
The Neonatal Infant Pain Scale is widely used. It's purely behavioral, looks at facial expression, cry quality, breathing patterns, arm and leg movements, and state of arousal.
And for post-op babies.
The CRY scale is designed for post-operative pain in neonates. It stands for Cry requires oxygen, increased vital signs, expression, and sleeplessness.
Got it. Now, what's the go-to scale for, say, toddlers or kids with cognitive impairments who can't self-report reliably?
That would definitely be the RFLACC, which stands for the Revised Face, Legs, Activity, Cry, and Consolability Scale.
Revised.
Yes, the descriptors were specifically updated and validated for use in children with cognitive impairment, making it incredibly useful for that population, as well as typically developing kids from about 6 months to 7 years who aren't verbalizing pain well.
Face, legs, activity, cry, consolability. You observe each category and score it.
Right, and the most important thing with any scale you choose.
Consistency.
Consistency. Use the same scale every time you assess that child. Switching scales makes it impossible to track changes accurately.
Okay, assessment is key. Now let's move to management. Always thinking about atraumatic care, minimizing distress. What's the foundation before we even talk about meds?
Non-pharmacologic strategies. They should almost always be part of the plan. We can group them into behavioral, cognitive, and biophysical methods.
Let's start with behavioral cognitive. What does that involve?
These techniques help the child refocus their attention or reframe their thoughts. Distraction is a big one, blowing bubbles, looking at a book, playing a video game, telling jokes, anything to shift their focus away from the pain.
Makes sense.
What else? Imagery can be powerful, especially for slightly older kids. You guide them to imagine a pleasant scene or experience in detail being at the beach, flying like a superhero.
Like a guided meditation.
Sort of, yeah. And relaxation techniques, deep breathing exercises, progressive muscle relaxation, even simple stroking or rocking for infants. Also, thought stopping, where you teach them to actively replace negative thoughts like, this hurts so bad, with positive coping statements like, I can handle this, it won't last long.
Okay, those are about changing the mind's focus. What about the biophysical methods? Things that physically interact with the pain signal.
Right. For infants undergoing brief, painful procedures like heel sticks, sucking in sucrose is remarkably effective. Giving a small amount of oral sucrose solution, often combined with non-nutritive sucking on a pacifier, provides significant analgesia.
Simple but effective.
Very. Then there's heat and cold. Cold packs help reduce swelling and slow nerve conduction, good for acute injuries like sprains. Heat increases blood flow, relaxes muscles, good for muscle soreness or cramps.
Standard stuff, but works.
And massage and pressure. Remember the gate control theory. Gentle massage, rubbing, or even applying pressure near the painful site can stimulate those large nerve fibers and help block the pain signals.
So combining these non-drug methods is ideal.
Absolutely. A multimodal approach is always best. But sometimes these aren't enough, and we need pharmacologic interventions.
Right. What's the guiding principle when giving pain meds, especially for ongoing pain like post-op?
The absolute golden rule is administer analgesics around the clock, ATC, not PRN, as needed. If you wait until the child is already hurting badly to give the next dose, you're always playing catch-up.
Stay ahead of the pain.
Exactly. Maintain a steady level of the drug in their system to keep the pain under control continuously. PRN is okay for breakthrough pain, but scheduled doses are key for persistent pain.
Okay, what are our main drug classes? Starting with the basics.
Non-opioids. This includes acetaminophen, Tylenol, and NSAIDs like ibuprofen, Advil, Motrin, or ketorolac. They're great for mild to moderate pain and often used in combination with other methods.
What's the main limitation with these?
The ceiling effect. Unlike opioids, giving higher and higher doses of acetaminophen or NSAIDs doesn't provide more pain relief beyond a certain point. It just significantly increases the risk of side effects like liver damage with acetaminophen or GI bleeding and kidney issues with NSAIDs.
So more isn't better past that ceiling.
Correct. And a critical safety warning. Aspirin is contraindicated in children and adolescents, especially with viral illnesses, because of the risk of Reye syndrome, which is a serious condition affecting the liver and brain.
Good reminder. Okay, when pain is more severe, we move to opioids.
Right. Morphine is generally considered the gold standard for moderate to severe pain. It's effective, we know how it works, and we can titrate it carefully.
What are the major risks we need to monitor for with opioids?
The most serious is respiratory depression. You absolutely must monitor respiratory rate and sedation levels closely, and always have naloxone, Narcan, the reversal agent, readily available.
Always have Narcan. Got it. Other side effects?
Nausea and vomiting are common. Constipation is almost universal with prolonged use. Itching can happen. Also, tolerance needing higher doses over time for the same effect, and physical dependence experiencing withdrawal symptoms if stopped abruptly after long-term use. These are expected physiological responses, not the same as addiction.
That's an important distinction. Are there any opioids we should avoid in kids?
Yes, the FDA has strong warnings against using codeine and tramadol in children under 12 and in some older children too, like post-tonsillectomy. Why? Because some kids metabolize these drugs ultra rapidly into potent opioid forms, leading to dangerously high levels and risk of overdoses even with standard doses.
Okay, very important safety point.
Mm.
What about managing pain for specific procedures like starting an IV or stitches? Local anesthetics.
Yes, topical anesthetics are crucial for atraumatic care. The most common is EMLA cream, a mix of lidocaine and prilocaine. It works well for numbing the skin.
What's the catch with EMLA?
The main drawback is time. You need to apply it under an occlusive dressing for at least 60 to 90 minutes before the procedure for it to numb effectively down to the depth needed for, say, an IV start. You have to plan ahead.
60 to 90 minutes. That requires coordination. Are there faster options?
There are some patches like Cinera that incorporate heat and work a bit faster, maybe 20-30 minutes. And for injectable lidocaine, like before stitches, you can buffer it with sodium bicarbonate. This reduces the stinging sensation when the lidocaine itself is injected.
Good tip. Let's touch on more advanced delivery methods. PCA.
Patient-Controlled Analgesia. This uses a computerized pump that allows the child, if they're old enough and understand, to push a button and deliver a small dose of opioid medication when they feel pain. It gives them a sense of control.
What's the big safety risk with PCA?
PCA by proxy. This is when someone else, a parent, a well-meaning friend, even sometimes staff, pushes the button for the child, often when the child is sleeping or sedated. This completely bypasses the safety mechanism of the child self-administering based on their own perceived need and level of sedation. It can lead to serious overdoses.
So strict rules against anyone but the patient pushing the button.
Absolutely critical. Education for the family is paramount. There's also epidural analgesia, where opioids and or dystoral local anesthetics are infused via a catheter into the epidural space in the back. Very effective for major surgery pain, like abdominal or chest surgery. Requires close monitoring of sensation, motor function, and respiratory status.
Right, that's specialized care. Circling back to procedures in general, what are some key atraumatic care techniques?
Beyond anesthetics, think about positioning. Therapeutic hugging, holding the child securely and comfortingly during a procedure, can reduce distress. Using the smallest gauge needle necessary helps minimize injection pain.
And for infants?
We mentioned sucrose and sucking. Also, kangaroo care skin-to-skin contact with a parent is incredibly powerful for comfort and stability during or after painful procedures.
One more thing about procedures, the location matters.
Hugely important when feasible. Try to perform painful procedures in a dedicated treatment room, not in the child's bed or playroom. You want their bed to remain a safe zone associated with rest and comfort, not pain and fear.
Makes total sense. Lastly, a quick word on chronic pain. We defined it earlier, pain lasting about 3 months or more. How does assessment change here?
With chronic pain, just asking for a pain score isn't enough. You really need to assess the pain's impact on the child's life. How is it affecting their sleep, school attendance and performance, social interactions and friendships, mood, physical activity?
And the family's life, too.
Definitely. Chronic pain impacts the entire family unit, stress levels, finances, daily routines. The assessment needs to be much broader, looking at function and quality of life. Management is almost always multimodal, often involving psychologists, physical therapists, and referral to a specialized pediatric pain clinic.
Okay, that's a lot of ground covered. If you had to boil it down, what are the absolute core takeaways for managing pediatric pain?
1. Pain is what the child says it is, or shows you it is, believe them. 2. Management must be individualized based on their development. 3. Use a multimodal approach, combine nonpharmacologic and pharmacologic strategies. 4. Assess frequently using a consistent, appropriate tool, and reassess after intervening. Stay ahead of the pain.
Excellent summary. Individualize. Use multimodal approaches. Assess consistently and believe the child. We started by mentioning that poorly managed pain in childhood might even contribute to chronic pain issues in adulthood.
It's a concerning link that research is exploring more and more.
So it leaves us with a final thought for you to consider. Knowing the potential long shadow of childhood pain, what specific, proactive, long-term support systems, beyond just giving the right dose of medication today, should pediatric nurses start thinking about integrating into care plans now to help mitigate those lifelong consequences and build better coping resilience for the future. Something to reflect on. Thank you for joining us for this deep dive brought to you by our dedicated team focusing on pediatric pain assessment and management. We hope this helps you provide truly informed and compassionate atraumatic care.